All right. Good morning, everyone. We will get started in just a little bit. If you don't mind going ahead and opening up the chat box, typing in where you are from. I'm so excited to get started with you all today. So let's make this a great session. Go ahead and open up your chat box. I'll be watching for your hello and where you're logging in from. All right. If you're just joining us, thank you so much for tuning in this morning. If you don't mind going ahead and opening up the chat box and telling me where you are logging in from and a quick hello, that would be wonderful. I see we have people tuning in on Facebook as well as YouTube and Zoom. So thank you guys so much. We're going to get started in just a little bit. All right. Well, good morning, everyone. Thank you so much for tuning in. Hope you all are doing well. I see that we have Natasha from Northeast Ohio, Riley from Northeast Ohio. We have Ariana from Houston, Sanaya from Virginia. Oh, wow. International audience, Aisha from Pakistan. Go ahead and type in where you are logging in from. I'm so excited to get to know each and every one of you. And also, if you don't mind, if you can hear me and see me, go ahead and type in yes into the chat box, please. If you can hear me and see me, go ahead and type in yes into the chat box. Excellent. We have so many people logging in. This is wonderful. I'm so excited to get started today. Excellent. Great. Well, thank you all for checking my audio and video. Today, we are going to be going through a very high yield session, and we are going to be covering high yield images you will see on exam day as it relates to respiratory. For many of you, this may be your first time tuning into my sessions, and I welcome you wholeheartedly. And if you have been to some of my sessions before and have been following me from the beginning, thank you so much for your support and welcome back. My name is Rahul. I'm currently in my last year of Pediatric Critical Care Fellowship. And over the past few years, I've been absolutely passionate about helping students just like you kick ass on the USMLE exam. And I'm so excited to share with you the way that I teach, the energy that I have, and the high yield material that we're going to be covering today. So just a few minutes about what makes my sessions and the way that I teach so unique. I know that there are so many resources out there, but what I really focus on is an evidence-based approach to learning as well as USMLE preparation. You'll see that all of my lectures are going to be rooted in active recall. I like to integrate across topics and interleave the different concepts. And finally, I like to focus on test taking strategy, because if I give you a systematic approach, my goal is going to be that you will then progress to thinking like the test maker and excel on your NBME practice exams as well as exam day. So when I look at preparing students in my courses, especially, this is what you're going to see. You're going to see, number one, integration of content. We're going to be focusing on different test taking strategies for different types of questions and concepts. I also am very passionate about giving you a study schedule. And that's why some of my courses that I have come with a study plan on Notion. And then finally, I realize that content is one thing. Integration is nice to hear, but I also like to focus on making sure you have a peak mindset when you are preparing. Most importantly, over these last few years of COVID, et cetera, I have been able to transition my live classes that I used to do in person at top 10 medical schools and transition it to an online audience. And here we are today, over 55 people joining in right now, global community of lifelong learners. And I'm so glad you're part of it today. So in case you missed it, in the past week, I did release 2 courses. Number one is my pass-fail course. Make sure you go to HyGuru.com and check that course out. It covers the top concepts that you need to know for your exam in a rapid review manner. I'm going to be doing a Q&A at the end, as well as giving you more information about it. And the second course, which comes with the study plan and brings private tutoring to the comfort of your own study space, is my test taking strategies and productivity course. I will be 110% talking to you about this at the end of the webinar. But first, I think it is just about time for us to go ahead and get started with our session today, high yield images for the USMLE Step 1 respiratory. If you all are ready, go ahead and type in yes into the chat box. Is everybody ready? Nushri is ready. Mary is ready. Excellent. Wow. Look at that. Everybody is ready to go. Let's go ahead and get started. So why did I create this webinar? Well, I really wanted to make sure we got good at the image-based questions for your USMLE and NBME exams. Remember that on exam day, you are going to have various types of media. You're going to have static images, you're going to have videos, they're going to give you physical exam descriptions. Maybe they place a video of lung sounds as it pertains to our session. You may even have some interactive media, especially when we talked about murmurs last weekend. So what I want you all to recognize from a test taking standpoint is that they will never flash an image and say, hey, what image is this? What can you give me as the diagnosis? An image will not be tested in isolation. That's pathology boards, that's radiology boards. The vignette really matters. And so I would encourage you to analyze the vignette as you are going to answer these image-based questions. So they will give you a vignette such as this, and they will highlight, they will say a photograph of the lesion is shown. So you will definitely want to focus here. And then once they guide you to the photo, you want to analyze this in a systematic way. So what is that systematic way? Well, this is exactly what I talked about in the introduction of this whole series of webinars, and that is the test-taking strategy for image-based questions. So when I see an image-based questions, I define the image. I say, Rahul, is it microscopic pathology, gross pathology, or radiology? In the last image, you saw gross pathology. Then I say, of what is this image? This is a gross pathology of the skin. So now you're defining what the image is, and then you are looking for things that you know, things that look abnormal, and when in doubt, asymmetry in the image. So I say, look for normal, abnormal, and asymmetry. And so I want you to practice this approach when you are going through your UWorld question banks, as well as NBME exams. Go through that systematic thought process. All right, so let's go ahead and go through an overview of today's session. What we are going to do, and this is, sorry, not cardiology, this is respiratory. What we are going to do today is go through physical exam findings in select lung diseases. You've probably heard of rales, wheezes, etc. This is found in the physical exam sentence in your vignettes. Subsequently, we're going to be talking about pneumonia as well as pneumothorax. Remember that there are 3 types of pneumonias that the USMLE wants you to know: lobar pneumonia, bronchopulmonary pneumonia, as well as interstitial or atypical pneumonia. We're also going to be talking about the pathophysiology of clubbing. Remember, clubbing is related to chronic hypoxemia. And then we're also going to be talking about ARDS, also known as acute respiratory distress syndrome. And there's a lot of GenPath tie-in here, but one of the ones that I want to give you right off the bat is ARDS has exudative infiltrates within the alveoli. Let's go ahead and get started with our first section, which is pulmonary physical exam findings for the USMLE. Let's get started with a question. So here we have a 6-week-old child who presents in winter with cough and congestion for 3 days. He has subcostal retractions and is tachypnic. His oxygen saturation is 91%. Physical exam shows diffuse expiratory wheezes and rales. Chest X-ray shows no focality. Which of the following is the most likely pathogen behind his current condition? Go ahead and put this answer into the chat box. What do you all think is the answer? Awesome. We have a lot of people saying D, and if you said D, you are absolutely correct. Now, what I really want you all to focus in on actually is this sentence right here. In my test taking course, I also talk about this in detail, but I want you all to recognize that this is what we call a pertinent negative. Whenever the USMLE puts the words no, negative, and normal into a test question, they want you to rule away from a certain diagnosis. And in this case, chest X-ray shows no focality rules out the possibility of pneumonia. And so this diagnosis is going to be what? If you said bronchiolitis, you are absolutely correct. And this is typically caused by RSV. So what we're going to do now is we are going to be going through some high yield lung findings that you will see in the physical exam in your vignettes. So let's go through crackles. So what do crackles represent? Well, to me, when I see crackles, it's either fluid or fibrosis. And remember, whenever you're talking about fluid within the lungs, you're going to be categorizing that GenPath tie-in as transudative, which is related to hydrostatic pressure, or exudative, which is related to infection, inflammation, or malignancy. Fibrosis also is going to be one of the findings when you hear crackles. Fibrosis can be seen when, for example, if you get a vignette that looks at or that talks about honeycombing of the lung, and that is the diagnosis of idiopathic pulmonary fibrosis. Either way, you will hear these crackles primarily on inspiration, and it just represents these collapsed alveoli opening up, and they're kind of stiff because of the fibrosis or having fluid in it, and they open up. Wheezing, on the other hand, is going to represent inflammation of the small airways, like the bronchioles, and bronchial hyperresponsiveness. So because of some sort of trigger that they will put in the vignette, you are going to have some sort of narrowing of those small airways. And whenever you have a narrowing, that decreases the radius of the airways, increases the resistance, and especially on expiration, you are going to have a sound or turbulence going across that narrowing, and thus you're going to hear wheezing. Typically, these patients who are going to have wheezing are going to maybe have asthma, some sort of bronchial hyperresponsiveness disorder. Primarily, it's on expiration. And remember, you're going to relate that to obstructive lung disease. And so you're going to have a progressive, prolonged exhalation phase. Stridor is going to represent upper airway obstruction. So you're not going to be thinking about the lungs. You're going to be thinking primarily the extrathoracic airway. So you're thinking about the larynx, for example. And so whenever patients have stridor, you're going to primarily hear this on inspiration. And you're going to say, something is going on in this upper airway. So what could be some of the differentials or some of the vignettes the USMLE Step 1 can give you? Number one, they can say, oh, the patient has fever and stridor. So whenever they have fever and stridor, you want to categorize whether it's epiglottitis, which they're going to look very sick in your vignette, or maybe it's going to be laryngotracheobronchiolitis or laryngotracheobronchitis, which represents croup. And in that case, you will see a steeple sign on your chest X-ray. Another cause of stridor is going to be bacterial tracheitis, which is an infectious cause. In this case, you may have what we call biphasic stridor, where you have stridor on both inspiration and expiration. And then finally, thinking about things like foreign body, which can cause stridor. Again, it's all upper airways with stridor. And then finally, you have fremitus. Now, fremitus is going to represent your sound waves going through a fluid or solid medium. The best way to kind of think about it is if you go ahead and take your finger and you put it right on your voice box and you go, do you feel that vibration? That vibration is basically fremitus. And you can also have egophony whenever you have fluid or solid. And this is all related to physics of how the sound waves traverse through a fluid or solid medium. So let's go ahead and go through this vignette. A 3-year-old male presents with acute fever and tachypnea. A translator is used during the exam as the patient and his family have recently immigrated from overseas. On exam, he has stridor, drooling, and is laying on his forearm. A lateral X-ray is shown. What is the likely morphology of the organism behind his symptoms? So I'll give you a little bit of time to just think about it to yourself and recognize that you want to go through that 3-step strategy. This is a radiograph of the lateral neck, and you see that there is this abnormal sign known as that thumbprint sign, and the morphology that you are going for here is a gram-negative cocobacilli. Because what does this represent? If you said Haemophilus influenza B or Hib, you are absolutely correct. And remember that Hib, this is a typable H influenza B. In this scenario, you are talking about an organism that is encapsulated and that requires a special agar that has NAD and hematin, or those X and V factors. So what is going to be the characteristics of the vaccine say that the patient was unvaccinated, remember that the Hib vaccine is a capsular polysaccharide and it is a conjugated vaccine. So the Haemophilus influenza type B vaccine is a capsular polysaccharide because it is an encapsulated bacteria that stimulates a B cell response. And the protein conjugate, that is very important because what that does is that gives you T cell activation as well as class switching. So the diagnosis here is Haemophilus influenza type B causing epiglottitis. And as you can see, this is going to be that inflamed epiglottis. So let's just quickly go through the anatomy of the laryngeal region. So here is going to be the epiglottis. And remember that the epiglottis covers the airway, especially when you're swallowing. Just for orientation purposes, this is the back of the tongue. So your back of the tongue, the epiglottis is going to be covering the airway, and that is what gets itis, inflamed in epiglottitis. You also are going to look at these vocal cords and see histologically, there is going to be a difference between the true vocal cords and the false vocal cords. The true vocal cords are the vocal cords that are here in white that are going to be rubbing against each other. And remember that this epithelium is going to be a stratified squamous, non-keratinized epithelium. The false vocal cords, that's going to be surrounding the true vocal cords. And in this scenario, it is going to be a pseudostratified columnar epithelium, similar to, for example, respiratory epithelium. That being said, I do want to integrate some embryology and anatomy, and that is to recognize that when you're talking about the laryngeal structures, majority of them are going to be innervated by a branch of the vagus, and that branch of the vagus is known as the recurrent laryngeal nerve. Remember that vagus branches off into the recurrent laryngeal nerve, and if the recurrent laryngeal nerve is damaged, say from thyroid surgery in your vignette, you will have a patient who presents with hoarseness. What's really important for us to know from an embryology standpoint is that the recurrent laryngeal nerve is going to be derived from the sixth pharyngeal arch. Ladies and gentlemen, this is how we prepare at HyGuru. We are going to be integrative. We're going to have active recall. We are going to make sure you focus on the high yield concepts. Let's go ahead and move on. Speaking of integration, we're going to go ahead and go through characteristics of vaccines as it relates to encapsulated bacteria. So for example, we talked about the Hib vaccine. The Hib vaccine is a polysaccharide and protein conjugate vaccine. The pneumococcal vaccine, you have two flavors. You do have the PCV13, which is the conjugate vaccine. Remember, protein conjugation activates T cells and subsequently class switch. Whereas your polysaccharide vaccines, those are primarily for B cell activation. The Hib vaccine is going to be conjugate, and the meningococcal vaccine is going to be conjugate. And remember that the meningococcal vaccine you get around adolescence, right before you're going on to college. You will really get tested, especially with the pneumococcal vaccine. You will get tested on these vaccines, especially when you see a Part A scenario or a question like this. Let's go ahead and go through this. A child with history of multiple admissions due to pain in his extremities presents with fever, tachycardia, and hypotension. He is found to have a blood culture positive for gram-positive lancet-shaped diplococci. If I just asked you, what is the organism that is a gram-positive lancet-shaped diplococci? Go ahead and put that into the chat box. What is a gram-positive lancet-shaped diplococci? Excellent. If you said strep pneumo, you are absolutely correct. And the pathogenesis here is that this patient has sickle cell anemia. And remember that in sickle cell anemia, these patients are actually going to be functionally asplenic. Why is that? Because they have repeat microinfarction of the vascular bed. And so if they don't have a spleen, they are going to be very susceptible to encapsulated organisms causing sepsis. And so what you have to recognize is that patients who have either anatomic or functional asplenia, they have decreased immunity towards encapsulated bacteria. And so one of the health maintenance exam questions they can ask you is vaccination, for example, against pneumococcus. Who are the patients that are going to be anatomically asplenic in your USMLE? Those are the patients who are going to be in car accidents. Maybe they had a massive rupture of the spleen, and then they had to have the spleen removed. The other high-yield sickle cell vignette related to infectious disease that you have to know is if the sickle cell patient presents with fever and bone pain, yes, you can think about dactylitis, but the other differential is Salmonella osteomyelitis. Salmonella osteomyelitis, one of the most common causes of osteomyelitis in the sickle cell population. All right, let's go ahead and go through our next topic. If you guys are learning, are active and engaged, enjoying this, go ahead and type in yes into the chat box. Excellent. Mary, Justin, Cheryl, Sonia, Claire, Tega, thank you guys so much for tuning in. Let's go ahead and go through pneumothorax. An 18-year-old male presents with sudden onset chest pain. There is no trauma. He has pleuritic chest pain. He has an uncle who had a similar presentation. However, his uncle passed away 3 years prior due to aortic dissection. On the patient's physical exam, his right chest is hyperresonant. Which of the following mechanisms contributed to this patient's presentation? A, apical subpleural blood rupture, B, penetrating trauma, C, hereditary intrapulmonary fibrosis, D, pan-acinar emphysema, or E, air trapping. What do you all think the answer is here? Awesome. If you're thinking about a spontaneous pneumothorax, you're absolutely correct. And the family history of connective tissue disease is also really important. Remember that patients who have Marfan syndrome may also have lens dislocation. And these patients who have Marfan syndrome, they are going to have poor fibrillin. And if they have poor fibrillin, they're not going to have good scaffolding of the extracellular matrix. Specifically, they won't have good scaffolding with elastin. And thus, you may have weak connective tissue within your lungs, and you can have a spontaneous pneumothorax. So spontaneous or simple pneumothoraces need to definitely be contrasted with tension pneumothoraces. So remember that simple or spontaneous pneumothoraces, you may have some pre-existing lung disease. These patients may have alpha-1 antitrypsin disease, for example, because they have this pan-acinar emphysema. They may have Marfan syndrome, which we just talked about. They may even have chronic lung disease due to maybe they're immunodeficient and they had chronic fibrosis due to infections. Either way, this pre-existing lung disease makes your lung weak and you can have rupture of apical blebs. This is especially seen in patients who are very tall and have a thin habitus. The key here is on X-ray, you will not have tracheal deviation. And that is contrasted from tension pneumothoraces. I remember that tension pneumothoraces usually are due to trauma. They have a mediastinal shift because now the air gets into the pleural space and causes you to have a shift of your mediastinum and your trachea away from the side of the trauma. And so what's important for us to recognize is that both pneumothoraces, both spontaneous and tension pneumothoraces, they are going to have decreased breath sound, hyperresonance on percussion, and decreased fremitus because it's an air medium. Remember, a pneumothorax basically means that within the pleural space, which is between the lung and the chest wall, there is air. And so this picture represents what a pneumothorax is. As you can see, the air is coming in between the visceral and parietal pleura. And here you see a lung image that has absent lung markings because the lung got collapsed. And you can see here on the left lung, you have collapse. And subsequently, when air enters here, it is going to push the mediastinum and the trachea to the opposite direction, to the right. So does this represent a spontaneous pneumothorax or a tension pneumothorax? Go ahead and put that into the chat. Spontaneous or tension pneumothorax? Absolutely. If you said tension pneumothorax, you are absolutely correct. Very good. The other pathology that you will see on your USMLE exam involves atelectasis. Now, the big picture concept is that atelectasis just represents a loss of lung volumes due to collapse of the alveoli. So, in certain mechanisms of disease, the alveoli won't be able to expand. And that is known as atelectasis, when they're collapsed and they're really not able to expand. So this could be due to obstruction. Say you had a foreign body, a mucus plug, or tumor. That could obstruct your main stem bronchi, and subsequently, you can have collapse of the alveoli downstream, or atelectasis. The mucus plug is very important for us to know, because you have to know that patients with bronchitis are going to have a lot of mucus plugging as well as cystic fibrosis. Remember that related to foreign bodies and aspirations, you're primarily going to have a right lower lobe aspiration when you have a foreign body, especially in a pediatric patient. There could also be a mechanism known as compressive atelectasis, in which you have a pleural effusion. In between your visceral and parietal pleura, there is an actual effusion. And that effusion, that fluid, is causing your alveoli not to expand. Think about another scenario, which is contraction. Fibrosis, for example, of the lungs is going to cause you to have contraction atelectasis. This is seen in your exam questions with late stage ARDS. This is also going to be seen in sarcoidosis, any inflammation that is going to give you downstream fibrosis. And remember that the cytokine that they love to test with fibrosis is TGF beta. The other important mechanism is going to be adhesive atelectasis. This is where you don't have surfactant. Think about your premature babies. Remember that your premature babies are not going to have an optimal lecithin to sphingomyelin ratio. And as a result, you are going to have high surface tension of the alveoli. And if you have high surface tension of your alveoli, you are going to have collapse of the alveoli. And so specifically in the pathology of neonatal respiratory distress syndrome, remember that these patients are going to be premature in your vignette, you are going to have collapse of your alveoli due to lack of surfactant. And because you have no surfactant, you have increased amounts of surface tension. As a result, you are going to have collapse of this alveoli, and classically, all the air will go to the proximal airways. And this is what we call air bronchograms. Collapse of the alveoli can be called ground glass opacities. So whenever you hear of ground glass opacities, that means that the small airways are basically going to be collapsed. And so ground glass opacities with air bronchograms in a premature baby helps you diagnose neonatal respiratory distress syndrome. Let's go ahead and go through this question. A 28-year-old female presents with cough and fever. She is found to have chest pain that is worse on inspiration. She's also had a 2-week history of arthralgias bilaterally. A chest X-ray is performed and findings are shown. So this is going to be a radiographic pathology of what? Of the chest, and look for normal, abnormal, and asymmetry, and look for the asymmetry, which is right here. And that represents a blunting of the costophrenic angle, which is consistent with fluid. An ANA shows a speckled pattern. What is the most sensitive lab test which may confirm the diagnosis? And I apologize for this typo. It's actually supposed to be what is the most specific lab test. Sorry about that. So what is the most specific lab test which may confirm the diagnosis? So putting this all together, this is actually the diagnosis of lupus. And when you're thinking about lupus, you are going to be thinking about anti-double-stranded DNA antibody or anti-Smith antibody, which represents antibodies to non-histone nuclear proteins. In fact, the classic teaching is that any unexplained pleural effusion in a young woman is considered lupus until proven otherwise. And so patients with lupus have what we call serositis. Their mucosal surfaces are going to be very inflamed. So for example, visceral and parietal pleura, they can be very inflamed, and that's why you can get this pleuritic chest pain as well as pleural effusions. And you could get pain worse with inspiration and a friction rub, which is consistent with another serosal surface that is going to be inflamed, and that is the pericardium. So patients with lupus are prone to pericarditis as well as pleural effusions. So this is going to be an integration of lupus. And I encourage you to also check out my syndromes YouTube video, which goes through all of the high yield syndromes you need to know for your USMLE. When we think about lupus, the skin findings are going to be the malar rash that spares the nasolabial folds. You can also have a variant called discoid lupus. Patients can have oral ulcers, again, representing mucosal inflammation. And patients can have Raynaud's phenomena, which is going to be vasospasm of the blood vessels in the extremities. This is seen right here. What are the vascular phenomena that patients have with lupus? Well, this is really important, that patients with lupus are hypercoagulable. And how that presents is recurrent spontaneous abortions. In fact, what you have, say at your placental vessels, you are going to have lupus, which causes inflammation. Inflammation downstream is going to cause endothelial injury that exposes subendothelial collagen and relates to a GenPath concept, which is Virchow's triad. And when you have that endothelial injury, you can get, number one, clot at the placental level, which can present as recurrent abortion, or these patients can have acute shortness of breath, tachypnea, and tachycardia, and hypoxemia, and you're worried about pulmonary embolism. So patients with lupus can have what we call antiphospholipid syndrome, and that's the mechanism that I just described. Hematologically, patients with lupus are going to have a type 2 hypersensitivity reaction, an autoantibody that is going to hit the red blood cells, white blood cells, and platelets. And remember that when you don't have good platelets, you can then have petechiae. Finally, I mentioned that patients with lupus have serosal surface inflammation, pericarditis, pleural effusions, and a specific endocarditis where you have vegetations on both sides of the valves, and that's known as Liebman-Sachs endocarditis. What I also want to integrate are the renal manifestations for lupus, because this is a common cause of morbidity and mortality in lupus patients. Patients with lupus may have a nephrotic syndrome presentation or a nephritic syndrome presentation. The nephrotic syndrome presentation is going to be the membranous nephropathy, in which you get a spike and dome appearance on electron microscopy. The nephritic presentation is going to be diffuse proliferative glomerulonephritis. And remember that diffuse proliferative glomerulonephritis is going to be progressing at times to rapidly progressive crescenteric glomerular nephritis. And that is really high yield for us to know, because this ends up being a patient on your USMLE that has some baseline kidney damage, but then bam, their creatinine goes up, BUN goes up, they're going to be anuric, etc. You're going to do a kidney biopsy that shows fibrin and macrophages, which are going to be the crescents that you will see on patients who have rapidly progressive glomerulonephritis. Remember, rapidly progressive glomerulonephritis usually has a precursor, and in lupus patients, that's going to be diffuse proliferative glomerulonephritis, where you have a wire looping of the capillaries. Let's go ahead and talk about our next topic, and that is going to be pneumonia. There are going to be a lot of infectious disease tie-ins with this section. What I really want you all to focus on is how microbes cause disease. In this case, how does strep pneumo, for example, cause pneumonia? This is a higher point. Essentially, what I want you to do is take all that nice stuff that you learned from Sketchy, and rather than having pictorial representations in your mind, learn it from a mechanistic standpoint. A 77-year-old male is brought in by emergency medical service after awakening with fever, chills, and chest pain that is worse on inspiration. Again, this is pleuritic chest pain. He has copious sputum production, And auscultation shows that the patient has decreased breath sounds in the right lower lung field. What are other physical exam features which may be present in this patient? So this is a little bit of spaced repetition from what we talked about in our first section. And that is the patient with pneumonia will have crackles. They will have dullness to percussion because it's a solid medium. They will have bronchial breath sounds representing that the large airways are now conducting air. And they may have tactile fremdus. So this is characteristic of, for example, a lobar pneumonia. And how does pneumonia present? Usually with fever, cough, and productive sputum. So what I want to integrate here are the different types of pneumonia, okay? Different types of pneumonia that you will see are going to be lobar pneumonia, which involves large portion of the lung, a whole lobe, as you can see here. Bronchopulmonary pneumonia, which usually represents many of the small alveoli, and it's a multifocal infiltrate. Sometimes the pathology can start here in the bronchi and then subsequently go down to the alveoli, and various different alveoli are going to be affected. And then you have interstitial pneumonia. And interstitial, or also known as atypical pneumonia, is usually going to involve both lungs, and you're going to have thickened alveolar septae. And this thickened alveolar septae are going to be in the interstitium of the lung, i.e. in between the alveoli and the capillary, there's the interstitium, which is the connective tissue matrix, and that is what gets thickened. So that's why patients with interstitial processes like fibrosis, like atypical pneumonia, for example, they can have hypoxemia. Why? Well, you have a diffusion defect. Just to tie in a little bit of pulmonary, here you have the alveolar capillary subunit, and we said that this is very thickened. So if you go back to Fick's law of diffusion, you have P big AO2 that cannot get into P little AO2. And subsequently, that increased thickness of the membrane causes you to have a diffusion limitation, and that's what can cause you to have hypoxemia. How does hypoxemia manifest on your USMLE? Well, it manifests as low P little AO2, or it manifests as low SpO2. The pulse ox in your vital signs in the question, that's going to be low, less than usually 90%. So as you can see, this patient has a lobar pneumonia. Now, would you diagnose this lobar pneumonia on the left or the right side? Go ahead and put that into the chat. Is this lobar pneumonia on the left or the right side? Excellent. You're absolutely correct if you're thinking about right-sided lobar pneumonia. Let's go ahead and go through some bacterial etiologies that are going to cause lobar pneumonia specifically. You have strep pneumo, classic one. Remember, it's a gram-positive lancet-shaped diplococci. If I say, what's a gram-negative diplococci, just as a sidebar, that's going to be Neisseria. Remember that strep pneumo has IgA protease and is encapsulated. The IgA protease is going to be one of the virulence factors that strep pneumo has. And remember that IgA normally is going to coat your serosal surfaces. The fact that you have sinuses, lungs, your GI tract, IgA coats all of that. And so if you have an IgA protease, the strep pneumo is going to essentially clip the IgA at the J chain, which is a very important immunology tie-in for you guys. Other important bacteria that is testable, Klebsiella. Gram-negative rod, you're going to relate this to aspiration. So patients who have stroke, alcoholics, patients who have Alzheimer's disease, maybe they have brain atrophy and thus their swallowing centers are not going to be as effective. And they can have this bloody mucoid-filled sputum, which is very diagnostic of aspiration pneumonia. Last thing that we're going to be talking about is MRSA or Staph aureus. Remember that this is going to be a patient who has a prodrome of flu-like illness. They have myalgias, fatigue, URI symptoms, and bam, they got really sick. They have fever, productive cough and sputum. This MRSA is gram-positive cocci in clusters. So let's go ahead and do a little bit of a matching game. Here are answer choices A, B, and C. Let's go ahead and start with this diagram first. Number one, This gram stain represents which one? A, B, or C? What do you think? This gram stain represents, you got it? A, yeah. What about this one? Number 2, which bacteria does this represent? A, B, or C? Excellent. And then the last one, you're absolutely correct. If you said that this is the gram-positive cocci clusters, that is going to be strep or staph aureus, excuse me. All right. So this is a slide that I like to call Think Like the Test Maker. Essentially, what I'm going to do is I'm going to give you some brief vignettes that are going to relate to a specific microbiological agent. Remember that the big picture that you guys already know now is that your pneumonia vignettes are going to present as fever, shortness of breath, pleuritic chest pain, sputum. They may even have a focal lung exam. So say that they have this exam and it's a neonate who presents with pneumonia. What's going to be the microbiological tie-in here? Well, they may be testing you on group B strep, E. coli, or listeria. Remember that GBS is a common cause in neonates, babies less than 28 days of age, common cause of pneumonia, sepsis, and meningitis. What if they said a college kid, and they may not have a focal exam, but they may have an interstitial bilateral exam? That's that walking pneumonia related to mycoplasma. Alcoholics are going to be prone to aspiration pneumonia. And remember that the mouth bacteria can actually go into the lungs, the aspiration pneumonia. And that aspiration pneumonia is usually due to anaerobic bacteria like Peptostreptococcus, et cetera. In this scenario, you need anaerobic coverage. So things like clindamycin is going to be an anaerobic type of antibiotic. What if they say that you have a hereditary disorder, pancreatic insufficiency, recurrent pneumonias? This is that multi-system involvement that you're thinking about cystic fibrosis. And remember that patients with cystic fibrosis are going to have MRSA infections. They may have Burkholderia infections. They may even have pseudomonal lung infections. HIV and pneumonia, you're going to be thinking about pneumocystis pneumonia. Some of the key microbiological characteristics is that you see ground glass opacities. The sputum is going to stain positive under silver stain. And we use Bactrim, which is trimethoprim sulfamethoxazole, for both prophylaxis as well as treatment. When it comes to pneumocystis pneumonia, you're going to be thinking about immunocompromised patients. So patients who have a low CD4 count, as in HIV or AIDS, or you're going to be thinking about transplant patients. Transplant patients, because of immunosuppression, they are going to also have interstitial pattern. All right, next one, smoker, COPD, and pneumonia. In this case, I want to really highlight Legionella pneumonia. Remember, Legionella, Moraxella, they love this hot, arid environment. Pseudomonas does as well. And this kind of wet, arid environment, Legionella loves to grow in. And you'll also see silver stain related to Legionella. So I want you all to kind of think about certain scenarios and certain paraphrases, because that will help you get good at forming these illness scripts on your USMLE exam. The other important aspect, which I want to relate to aspiration pneumonia, is going to be a patient who has persistent fevers and their pneumonia is not getting better. So what they'll say on your USMLE questions is they'll say something like, they had a course of antibiotics, but the patient continues to be febrile. What do you think is the diagnosis? And in that case, you want to consider a lung abscess. And why does the USMLE like to go for this? Well, it's because when it comes to an abscess, that is a walled off area in the lung, i.e. the epithelium is going to wall off the infection, and thus you're going to have decreased penetration of antibiotics. All right. This is an important slide because it goes through the microscopic pathology of pneumonia. You remember you have the congestion phase where you have exudative. Remember, exudative, extra protein, extra LDH, extra neutrophils. That occurs in the first 24 hours in lobar pneumonia. Then you're going to have the red hepatization phase. Remember, hepatization looks like liver on gross pathology then. And so when you see this under the microscope, you're going to see neutrophils, erythrocytes, that's why it's red, and fibrin. And this occurs within the 48 to 72 hour range. And then finally, you have the gray hepatization phase in which the erythrocytes are going to be resorbed and you're going to see fragmented RBCs, more fibrin, and this will occur around 1 week. Also important for us to recognize is that resolution of pneumonia usually occurs due to the stem cells, which are in the basal layer. That's a very important histology point. Stem cells regenerate. And if they ask you, what is that stem cell that helps you regenerate your lung epithelium, that's going to be type 2 pneumocyte. Type 2 pneumocytes, two functions, surfactant and stem cell. Let's go ahead and transition to bronchopneumonia. When you're thinking about bronchopneumonia, remember it starts in the proximal airways, that's a big picture, and then subsequent extension of the infection into the surrounding alveoli. And what you can see here is that these patients have these multifocal infiltrates, and you can see that bronchopneumonia has patchy areas of necrosis, as you can see in the arrows right here on the picture. And these patchy areas of necrosis and inflammation represent collections of neutrophils in the alveoli as well as in the bronchi. So multifocal infiltrates is a characteristic of bronchopneumonia. Let's go ahead and go through this question. A 20-year-old male presents with 12 days of cough, low-grade fever, and malaise. The cough is non-productive. His lung examination shows scattered rales. He is also noted to have anemia and elevated LDH. Scleral icterus is also noted on repeat eye exam. What is the likely mechanism behind his presentation? Is it type 1, type 2, type 3, or type 4 hypersensitivity reaction? Go ahead and put that into the chat. What do you all think the answer is here? All right, this is a really interesting question. And essentially, let me explain to you the pathophysiology. What is happening is that the patient has a walking pneumonia due to most likely mycoplasma. And with the immune reaction, remember that mycoplasma can present IgM. And that IgM can actually then attack red blood cells. And if they attack red blood cells, you, by definition, have a type 2 hypersensitivity reaction known as autoimmune hemolytic anemia. That's the heme tie-in here. Remember that in your questions, you'll see something that says Coombs positivity, which represents autoantibodies sticking on the red blood cells. And subsequently, red blood cells are now popping. And when they're popping, they're going to have cell injury, which is high LDH. They're going to have high indirect bilirubin. And that's what is causing this patient's scleral icterus. Okay. So ladies and gentlemen, what's really important is for you to think of a lot of these pathogenesis questions in a very mechanistic way. All right, very good. So the answer here is going to be type 2 hypersensitivity reaction. So this integrates autoimmune hemolytic anemia. This is also seen in my NBME Top Concepts hematology lecture. What we just talked about is the cold autoimmune hemolytic anemia. And I remember, yum, cold ice cream. So it's going to be IgM. This is going to be due to infections like mononucleosis and mycoplasma. You're also going to see it in CLL. And you may even see livedo reticularis, which is a net-like rash on your skin exam. And livedo reticularis can be seen in cold autoimmune hemolytic anemia, as well as cholesterol embolism. So that's also a high-yield NBME point, okay, in which the cholesterol plaques say that the patient has very atherosclerotic risk factors. They go in for some procedure, such as a heart cath, and the cholesterol plaque gets dislodged, hits the microvasculature within the foot, you get livedo reticularis. Warm autoimmune hemolytic anemia, this is going to be due to some sort of drug trigger. It could be also seen in lupus, but this is IgG. In both cases, you are breaking down RBCs, so you're going to have release of heme, and that subsequently breaks down into indirect bilirubin. So what are you going to see for mycoplasma on your USMLE? Remember that mycoplasma doesn't have that peptidoglycan cell wall. It has cholesterol membrane. These patients are going to have a lot of interstitial inflammation. And that's why you're going to get that atypical symptoms. Remember, atypical pneumonias, they typically don't have that productive cough, and they're going to have this low-grade fever. They also may have this erythema multiforme presentation. And the pharmacology that you have to know is that with these organisms, atypical organisms, you're going to use macrolides, things like azithromycin, erythromycin. And remember that they are going to inhibit your 50S ribosomal subunit. Continuing on, a 5-year-old male presents with cough at night. He has had this for the past 5 months. The patient has a history of seasonal allergies and scaly rash on the flexural surfaces. His lung exam shows no wheezing. Spirometry, however, is notable for a decreased FEV1. The patient may likely have which cytokine elevated in the blood? IL-1, IL-5, IL-12, or interferon gamma? What do you all think is the right answer here? Excellent. If you said IL-5, you're absolutely correct. What I want to really highlight here is the fact that this patient is very atopic. And so the patient has allergies, the patient has eczema or atopic dermatitis. And when they present with cough, especially at night or especially with activity, for example, that is chronic, you're going to be thinking about asthma as your diagnosis. Okay, so let's go ahead and think about the microscopic pathology images that you'll see with asthma. What are the characteristic pathological hallmarks which may be seen in the sputum? Well, you may see Kirschmann spirals, and that's here. And Kirschmann spirals represent epithelium that are shed as you're having those forceful coughs. And it's the epithelium that's shed from the actual airway. Charcot-Leyden crystals represent these needle crystal aggregates of this MBP protein from the eosinophils, the major basic proteins from the eosinophils. And remember that IL-5 is going to be the cytokine that recruits eosinophils. And eosinophilia, high amount of mast cells, these are all characteristics in patients who are going to have asthma or atopic diseases. So asthma is really going to be on gross pathology. There's going to be a lot of hyperplasia of mucosal glands, and there's going to be a lot of smooth muscle hypertrophy. And that's what gives you that hypertrophy, as well as hyperplasia, gives you the bronchial hyperresponsiveness due to some sort of trigger. So just to review, what would microscopic pathology of a bronchus show in asthma? You will see that the patient has mucus in the lumen. They have inflammation of the basement membrane. They have actual membrane thickening. They have these enlarged mucus glands that you will see, and they have a lot of smooth muscle hyperplasia. You're going to have the thickness of that lumen of the muscular layer going to be greater. And as a result, you are going to be thinking of the pharmacology integration, which is beta-2 agonism. Remember that albuterol helps dilate the bronchi by causing smooth muscle relaxation, and it does that by activating the GS pathway and specifically increasing cyclic AMP. Another interesting finding that you will see not only in, for example, cardiac tamponade, but you will also see in obstructive lung diseases like asthma is going to be pulsus paradoxus. And remember that in asthma, you get a lot of air trapping. And that air trapping is going to cause you downstream to have a fat alveoli that may compress the subsequent capillary that is right next to it. Now, this air trapping with the local compression of the alveolar capillary is going to cause you to have increased pulmonary vascular resistance. So as you can see in this image, the heart is trying to pump against now a high pulmonary vascular resistance circuit. What's specifically happening here is that the right ventricle is trying to push against a high PVR circuit. And what ends up happening is that the interventricular septum bulges into the left ventricular outflow tract. And when the interventricular septum is going to bulge into the left ventricular outflow tract, especially on inspiration, when you have a large amount of preload coming into the right ventricle, you are going to get a decrease in about 10 millimeters of mercury. You're going to get a decrease in your blood pressure because of that LVOT obstruction. And so that's how obstructive lung diseases are going to have pulsus paradoxus. It's that septal shift into the left ventricular outflow tract, especially on inspiration. We are almost done with our webinar. We just have 2 more short topics to go through, but I just want to ask you all, if you guys are active and engaged and enjoying this session, go ahead and type in yes into the chat box. Excellent. Your guys' energy really, really drives me. So I appreciate you all typing in the chat box, etc. And remember, at the end, we're going to have a nice live Q&A. I'm going to answer all your questions and highlight my resources as well. All right. Excellent job, guys. Let's keep going. Patient with cystic fibrosis presents with foul smelling, green sputum, and cough. A chest CT is ordered. So this is a radiographic of the chest, and you see that there are scattered dilations of the proximal airways. So what is the likely diagnosis here? If you're thinking about bronchiectasis, you're absolutely correct. Remember that bronchiectasis represents the airway integrity getting broken down, and now you just have the persistent dilatation of your proximal airways, your main stem bronchi, for example. And so as you can see, look at these airways that are just going to have a high luminal caliber. In bronchiectasis, you are going to have some sort of trigger that is chronic. Things like cystic fibrosis, because you don't have good mucociliary escalator, Cartagena syndrome, primary ciliary dyskinesia, tuberculosis, any infectious etiology that's going to linger. As a result, you're going to have destruction of airway cartilage and elastic tissue that leads to persistent dilation of the proximal airways. And so as you have airway damage, you can get hypoxemia. And chronic hypoxemia causes your extremities to change and you get clubbing. Now, just to back up a little bit, remember bronchiectasis, they may even have hemoptysis. And that's because you are going to get persistent dilatation of the proximal airways. Maybe there's increased amount of mucus. And when you are coughing, the patients in your vignette may have blood-tinged sputum when they have bronchiectasis. And that just represents that the forceful cough shears the bronchial arteries as the air is propulsed out into the environment. This is a picture of clubbing that you may see. And remember that when you see clubbing, you're going to be thinking about bronchiectasis, psoriasis. You're also going to be thinking about malignancies like squamous carcinoma of the lung. And you're going to be thinking of cyanotic heart diseases, anything that really gives you downstream hypoxemia. Our last topic of the day today is going to be ARDS. Let's go ahead and go through a vignette. A 50-year-old female is admitted for costovertebral angle tenderness and fever. On day 3 of hospitalization, she is admitted to the ICU as the patient has increased hypoxemia. So she had pyelo and now she has hypoxemia. The patient has multifocal airspace disease on X-ray, which are new. What additional pathologic finding may be found in this patient? A, exudative airspace disease. B, transudative airspace disease. C, non-caseating granulomas. Or D, red infarct of lobar segment of the lung. What do you all think the answer is here? Awesome. So I'm having some great answers here. And if you said exudative airspace disease, you are absolutely correct. Remember that this is going to be very characteristic of acute respiratory distress syndrome, in which you had a trigger, in this case, pyelonephritis, and that downstream caused a lot of inflammation in the lung and subsequently caused hypoxemia. So ARDS, we're seeing this even in COVID patients now. Here's another vignette that highlights it. A patient presents with pancreatitis and is suddenly intubated with a prolonged course in the ICU. He requires increased oxygen requirement and has new infiltrates on chest X-ray. What is the likely pathological finding this patient may have on alveolar analysis? So these patients are going to have hyaline membranes that are surrounding the alveolar capillary membrane. So if you look at the alveolar capillary membrane, and because there is going to be a space because of inflammation in your pulmonary capillaries, that ends up having all of this rich inflammatory exudate that is going to be at the interstitium of the lung and between the capillary and the alveoli, as well as exudative infiltrate within the actual alveoli themselves. So ARDS, your lung becomes very, very stiff. What do you think the pulmonary capillary wedge pressure is in ARDS? This is also a surrogate of left atrial pressure. Go ahead and type into the chat, high or low. What is the pulmonary capillary wedge pressure in ARDS? High or low? Awesome. If you said normal or low, totally fine. Remember, pulmonary capillary wedge pressure is normal in ARDS. And let me go ahead and just quickly illustrate that. In ARDS, there is essentially a lot of inflammation within the lungs. And so you'll have new infiltrates. But whenever you see these new bilateral infiltrates, for example, you're going to be like, whoa, new infiltrates? Is this going to be, for example, your left ventricle failing and subsequently backing up into the LA and then into the lungs? And so in ARDS, because it is actual issue with the lungs, and it is not representative of, for example, heart failure, your left atrial pressure is going to be normal. And so what is a surrogate of left atrial pressure that we use? Pulmonary capillary wedge pressure. So pulmonary capillary wedge pressure and left atrial pressure is either normal to low in patients who are going to have ARDS. And that's extremely high yield for you to know. So elevated pulmonary capillary wedge pressure is more suggestive of left ventricular failure. And that left ventricular failure causes backup into the lungs. And you can have bilateral infiltrates, but that's a different mechanism. So in ARDS, remember, you are going to have this hyaline membrane that is going to occur because of the inflammation at the alveolar capillary subunit. And it is neutrophils that are primarily going to be responsible for this. And they can also break down the structural integrity of the lungs. Now, ARDS, what's high yield is that in your vignettes, you're going to have a trigger. And that trigger is then going to cause you to have inflammation. What are the triggers we just saw? Well, for example, any sort of infection like pancreatitis or any sort of inflammation, just like pancreatitis. In ARDS, that infectious or inflammatory trigger is going to cause you to have a lot of inflammation in the lung. For example, IL-8 is going to then recruit neutrophils. You have capillary membrane that is going to dilate, especially at the alveolar capillary subunit. And subsequently, you are going to have downstream effects such as decreased surfactant, hyaline membrane. Remember, when you have decreased surfactant, the alveolar surface tension is going to go up. You're going to have collapse of those alveoli. And in the fibrotic phase of your ARDS, your lung is just going to be very damaged. And that's going to be downstream, not in the acute phase, but in the resolution phase. And you're going to have progressive fibrosis of the lung. So what I do want to do is highlight an important concept, and that's from BRS physiology, and that is pulmonary compliance. Remember, compliance is going to be your change in volume over your change in pressure. It answers the question, how easy is the lung going to fill? So in ARDS, is your compliance high or low? Go ahead and put that into the chat box. In ARDS, is your compliance high or low? Exactly. You have very poor compliance because in order for you to get any sort of volume of air, your denominator, you have to really have high amount of pressures. And so remember that compliance is inverse to elastic recoil. So what are pathologies that increase compliance? Well, things like emphysema, aging, whereas decreased compliance, you're going to have things like ARDS, pulmonary fibrosis, where your lung becomes very, very stiff and it takes a lot of pressure to fill open that lung. Ladies and gentlemen, we have just finished our session today. Thank you so much for joining. But before you leave, I just wanted to have just a few announcements for your preparation and your learning, as well as the subsequent webinars. Please make sure right now, when you are going to be logging in or logging off, right before you log off, go ahead and go through and Google HyGuru Trustpilot. Go to my Trustpilot page, and on my Trustpilot page, you will be able to write a review of what you thought about this session. I want your honest feedback. Please go ahead and write a review right now. As soon as you write a review, within 24 hours, as soon as you write a review, I will enter you for a raffle, and you will get choice of a course, as well as you'll do a 30-minute private tutoring Zoom with me. I just want to get to know you on a personal level, and I want you all to provide me feedback as I am going to go through these lectures with you in the subsequent weeks. Just to give you a brief overview of my resources, I have released my study schedule and test taking strategies class. This class helps you understand how to study for the exam and how to approach different test taking strategies. And that's very important. You also get a customizable Notion study plan that you can use throughout your school preparation as well as your dedicated study preparation. What this plan and this course has is a customized table for you to input your UWorld notes. What I've realized is that a lot of the question banks have very, very long explanations. Do you guys agree? Say yes or no in the chat box. Do you guys agree? A lot of long explanations. It takes a lot of time. Absolutely. Cheryl, Anushri. Yeah, you're absolutely correct. And so what I've done is I have created a customizable table in which you can have questions that can help you tackle the UWorld explanation. And I think that that will really help you get through UWorld in a very concise way. In this course, you will also learn test taking strategies. How do I approach EKG questions? How do I approach, for example, your graphs and charts? This is going to give you a one-on-one tutoring like experience where we go through the strategy, and then you're in the next video, you go through the actual multiple choice question. So enroll in this course. It's at HyGuru.com. Everything is under my resources page on HyGuru.com. Very easy to find. It's about 8 hours. Also is going to have some farm drills that are integrated in there because I want to make sure that you're staying active and engaged. And that brings me to my next course. This is the last course. This course is called the Pass Fail course. You want to learn the high yield rapid review information? Please sign up for this Pass Fail course, because what I've done is I've taken the Pass Fail content outline, and within 50 hours, you will go through the highest yield concepts that you need to know. Everything from pathology, pathophysiology, physiology, biochem, pharmacology. And what I want you all to recognize here is that in this course, you will get access to mapped UWorld questions. And mapped UWorld questions will allow for you to watch a very high yield video, and then you can make a customized block based on the question IDs that I provide. And that block will then allow for you to solidify the information. So this is a unique way of learning. You go through the concepts in an active recall, and then subsequently you make multiple choice questions to really solidify the information. Again, pass-fail course right on HyGuru.com. I want to thank you, each and every one of you, for joining today. Looking forward to your reviews on Trustpilot. And please make sure you post my content and share this with your colleagues. I really would appreciate it. It really is a ground level project that I'm just trying to get more support on. So I really, really appreciate your support. Thank you all for joining. Next weekend, or sorry, the weekend after that, because I'm on call. The next weekend, I will be going through renal NBME high yield images. And please make sure before you leave, you type in one thing into the chat box that you learned from this session that's going to help improve you as a USMLE test taker. All right, type in that one thing, and we're going to start our live Q&A. Thank you guys so much for tuning in.